Wow, well, thank you, and I suppose I should say a warm welcome to this talk. So we're looking at evidence-based communication. Now, I've put this picture up here because that's me on top. And this is, this one below is called, is it Grummet or Wallace, that one? I always get them mixed up. yeah. And people send me pictures in. It's just a reminder not to take yourself too seriously, really. So whatever I say, whatever you do, compare it to the evidence. We have to be grounded in reality. And we've got this topic here, health, disease, and dis-science, Professor Clancy's term that I've pinched. But it does sum up a lot of what we're seeing, that science has been subjugated very often to vested interest, and that's a problem. So this is Hadrian's Wall, up near where I live. It goes up hills and it goes down dales and it goes along and you can follow it along. And that's like the evidence. You follow it wherever it leads. You know, and it might take you places that are pretty uncomfortable. This is a C.S. Lewis phrase. And it took me to places that weren't very comfortable, really. As you rightly said, all my entire life, you follow guidelines. If something goes wrong at work, the first thing is, did you follow the guidelines? Are you teaching the latest guidelines? And that carried on. And I had trust in people that wrote the guidelines. But then it started contradicting the evidence. And if it contradicts the evidence, you know, you've got to go with what the evidence says. We have a scientific method. We have a way of doing this. And if it contradicts that, then there's something wrong. Uncomfortable, but as you say, it's a realization. And now we have to really strive for the evidence, regardless of what anyone says. So Professor David Sackett, we formalized the ideas of evidence-based medicine back in the 90s. It's been around for a long time, but he put it together. And he had several ideas. Best available evidence, we need that. Expert opinion from around the world, and what patients like, patient preferences. Put those things together, and we get evidence-based medicine, evidence-based practice. But how feasible is that at the moment? So best available evidence is communicated via, very often, medical journals. And if there's a problem with medical journals, we have to move on to other types of communication, and that's what we're doing now, really, this idea of evidence-based communication. And this is from one of the articles. Who controls the journals? Who controls the trials? Because the trials that are done are the trials that are paid for. So a randomized double-blind controlled trial, well, they start at about $10 million each. You know, has anyone got some spare cash on them? These are paid for by large-scale vested interests. So questions that might be useful, well, we're not going to bother with those unless they make some money. Issues that might be completely useless or deleterious, well, yeah, we can do those if the money's there. So who controls the trials is the problem. So, for example, medical journals are an extension of the marketing arm of the pharmaceutical company. These are from published papers. And Richard Horton, who was editor of The Lancet for a period of time, journals have developed into information laundering operations for the pharmaceutical industry. Very often, he who pays the fiddler calls the tune. So, and they're very, very good. They're pretty slick. Best available evidence. Very well written, brilliantly written, these things very often. But the right studies are often paid for. And if you ask the right question, you get the right answer, don't you? We've all done this, haven't we? Yeah. I try it with my wife sometime. It doesn't really work, but you know, you ask the question that you think will get you the right answer. It's called a leading question in communication theory, isn't it? But the questions that are really right, then very often simply aren't asked. Inclusion and exclusion criteria. So, for example, if you're doing a trial and you exclude people that are getting particular side effects, your results look better. And these often can be changed as the trial goes on, which is really quite naughty. Time frames. How long does this benefit last for? So do people get antibodies? How long do they get them for? Do they feel a bit better for a short time? But what about the long-term effects? If you pick the time that you take your results from, again, you can influence what the result looks like. And these are all strategies that are used. So really, these very clever people with very expensive clinical trials don't actually need to fiddle the results. The result is almost an fait accompli before the trial is even done. This is what we are up against. And again, negative results, very often no need to suppress them because the results are engineered to get the result that you would like to get. And then there's other issues with completely fraudulent papers as well, things that people just sit down and make them up. So that's another issue. 10,000 sham papers have been retracted by academic journals. And again, this is from The Guardian. And I think we can make copies of these slides available, and all the references are there, as you would expect. Expert opinion. Can we trust expert opinion? Well, this is from some little organization, FDA in the United States, Food and Drug Administration. And now the horse, I think that's the one on the left with the long face. Because obviously this is horse medicine, horse-pace medicine. And this message works. You know, I met an American once and we were chatting about this, and he said, you know, one of our politicians was recommending horse-pace medicine. You know, they actually believe this. This is put out by the FDA. You remember that slogan, come on you all, you're not a horse, you're not a cow, stop it. So obviously a horse medicine. But they don't mention that there's been over 3 billion prescriptions of ivermectin taken by human beings. They don't mention that we're still prescribing 250 million doses of ivermectin per year to human beings. Quite incredible. And they forget to mention it won the Nobel Prize in 2015, of course. Santosha Moore and William Campbell, who's not related to me, but... Yep, expert opinion. European Medicines Agency, 89%. Therapeutic Goods Administration, 96%. FDA, 56%. This is the one in my country, Medicines and Healthcare Products Regulatory Agency, 86%. Japan, 85%. Canada, 50.5%. What are we talking about? Industry funding. These are the percentages of the budget of these organizations that describe what goes in your body, what goes in your loved ones' bodies, or what is not allowed to go in your body or your loved one's body. That's the percentage funded by industry. And I've got a new phrase now. He who pays the fiddler has absolutely nothing to do with the tune at all. How can these organizations be objective and scientific, clinical, independent decision makers when they're 96% funded by? It's just a bit silly, really. And then we have another problem. Oh, my picture's moved there, but never mind. FDA, 9 out of 10 commissioners went on to roles linked with the pharmaceutical companies. This is called the revolving door. And if you are in power and you know that there might be a job that earns a few bob coming up at the end of it, again, that's going to have nothing to do with your decision making at all. Nothing to do with it. So Sir Patrick Vallance in my country, he came from Big Pharma and became our chief scientific officer. This is the guy that the Prime Minister sat at the feet of and took notes from. And then this one, Deputy Chief Medical Officer, Sir Jonathan Van Tam. He was our Deputy Chief Medical Officer, again, massively influential. And he now works for a company called, what was it called? I think it's Moderna. For an undisclosed, now works for Moderna for an undisclosed salary. And I should just say that when I do the videos, I know I'm being a bit sarcastic now, but when I do the videos, it's not me trying to be funny. It's the algorithms. the AI, artificial intelligence. So I've got this kind of look when I do a kind of a look over my glasses like this. You sort of give it a funny. I used to do that with students. It works quite well. But the point is, the artificial algorithms don't pick that up. It's really quite serious. So the silly sarcasm is actually to fool the algorithms, and the algorithms are so stupid. Artificial intelligence is so stupid at the moment it doesn't recognise sarcasm yet. So that's what that is about. So revolving door, bit of a problem. This is the Ministry of Truth building in Carlisle. It's actually a telephone exchange with very nice people in, but it looks like the Ministry of Truth building. But how dare you question me? I'm in authority. Just do what you're told. Comply. Obey. Patient values and preferences have to be predicated on informed consent. If we don't have the best available evidence, if we can't trust our experts, how can we possibly have informed consent? It just becomes impossible. Single narrative is Hobson's choice. You can have any colour you want, as long as it's black. Unfortunately, it's the position. But we will choose to think for ourselves when we are allowed. This was built by our Neolithic ancestors on the Orkneys. They thought it through. We can think it through as well. We will think for ourselves. Thank you very much. We will use scientific principles that we've learned our lives working out. We will talk to experts that we trust. And if anything as good has come out of what's happened over the past few years, I've now got a network of people around the world that I really trust. It really is quite humbling. We need to do this as well. We need to develop these networks of trust, because there are more threats coming to the way that we communicate now online. Governments are trying to clamp down on freedom of social media. So evidence-based communication as a primary source publication. So Professor Clancy actually released some new data on my video for the first time. It becomes a primary source publication that people can peer review. So it was really quite a nice thing to do. We can look at the evidence, we can look at the data. Also on videos, of course, we can get first-person testimony. Mel kindly came on one of the videos, and people have come on the videos and described their suffering. And that is, it's just a noble thing to do. It's a humbling thing. People come on and tell me how they've suffered, how their family have suffered. And what is more authoritative than that? If we don't listen to our patients, what good are we? We can have expert opinion. We have these networks of trust. We can even have some specimens, some medical specimens we might see in a minute. And we can work out the best ways to apply these things as well. That's part of what we can do with evidence-based communication. Now, this should rotate, but never mind. This was in a glass case in Oxford College in Oxford University. It's an adenovirus vector. Oh, there we go. Thank you very much. There we go. It's in a glass case. Now, I think they might have put a blanket over it now to try and keep it quiet. But the vaccines have been an obvious case in point where initially it looked good, but then not so good. So this is an example of evidence-based communication, and time allowing will give you some more examples. But can we evaluate the efficacy of these and the adverse events of these? So this is data from Western Australia. What happened at the blue line? That's when the COVID vaccines were introduced. And that's the difference it had on the reported adverse reactions. Massive increase. And this is duplicated around the world. And I'm not quite sure of the figures in the UK, but the adverse events reported in the yellow card system in the UK are probably 2 to 3% of the actual adverse events. And certainly not more than 10% of the actual adverse events. So basically, we are well within the limits of reasonableness if we put a 0 on the end of these. And that applies to the reported deaths. It applies to the... Very often, a death will occur, an adverse reaction will occur, and it's simply not linked in the mind of the person that's doing it. So a big part of the problem to me has been the Topsy curve. If you put another brick on here, can you see it's going to fall over? And this is partly what fooled me. So the lower bricks are vaccines. So we started off with vaccines. And vaccines have been an efficacious treatment all my life. But then they carried on, and these new ones, these adenovirus vectors and these mRNA products, they're actually not vaccines. I was fooled by that. I thought these were vaccines. But they're not. They're genetic products that tell the body to produce an abnormal protein. And it gets further and further away from our original understanding. All my life I've talked about Edward Jenner giving James Phipps cowpox. But it's got further and further and further away from that. Until now, it's just unrecognizable, and the pile has fallen over. The Topsy curve. We have to go back to fundamental principles rather than saying, well, that's what we did last year, that's what we did 6 months ago, that's what we're going to do now. And then you get further and further away from the original science. And that's what's happened. And I see it clearly now. Another example, a new pathology. Now, this is really quite strange. I'll flick through these quickly. They're a bit gory pictures. But this is Richard Hirschman, and he's pulling these clots out, or whatever they are, during the embalming process. Now, if these only occur in the deceased, then it's still a new pathology. It still needs to be explained, and just about no one's talking about it. I was able to do an interview on GB News about this, but apart from that, it's been on no mainstream media at all. But these things exist. They're in bottles. Mr. John O'Looney works in England, and he's seeing exactly the same thing. And the doctors amongst you all recognise the casting, that's the lower part, we think, of the aorta, that material was taken from. Okay, these are in the deceased, but the point is they didn't occur before. This is new. What's going on here? And this is a great example of what I would call citizen science, really. This is Major Tom Haviland, ex-United States Air Force. He's taken the data in, he's done his own surveys, he's done the work, and we were able to publicise that. And an average of 20% of corpses in 2023 and 30% of corpses in 2022 had these things, and they weren't there in the past. And what I can't understand is why Major Tom's got to do this. Why aren't the world's pathologists chomping at the bit to get there first? This is, pathologist Campbell could call this Campbell disease, Why aren't they doing that? It really is quite strange. And it's in an average of 25% of corpses in 2023. And again, he's collected the data on that. Quite incredible. Excess deaths, of course, are another major concern. And again, let's look at the data. Now, where's this? This is Australia. Okay, so Australia, this is OECD, Organisation for Economic Cooperation and Development, which is still, seems at the moment, you data people will know better than me, but it seems at the moment they're still publishing good data. It seems at the moment. So Australia 2022, 18.7% excess deaths. This is huge. More than deaths than we would expect. Weeks 1 to 34 for 2023, where we have the data, 16.8% more deaths than we would expect. This really should be top of every newspaper. This one is the United States. Hope that reduction is real, but again, the United States, 17.53%, 7.8% above what we would expect. And these are from Our World in Data, which is a reliable source. United Kingdom, we were a bit uncomfortable with the way that the data was being recorded in the United Kingdom. So the Office for National Statistics helped by changing the way that the data is collected. Quite incredible. And I looked at the data from 2023, and in every instance I looked at, the old data was showing more deaths than the new data, the way of collecting it. That doesn't mean to say that there's less bereaved widows. Doesn't mean to say there's less burials and cremations. Doesn't mean to say there's less missing sons, daughters, mothers, but it looks better. So hey-ho. Yep, 9.44% in the UK, excess deaths. Japan. Why aren't people flying to Japan to work out what the heck's going on here? It's still going up in Japan. The other thing I like to do in evidence-based communication is feel free to ask simple questions. So this question is, what happens if you stick a needle and syringe in a bottle of red ink and draw back? Well, you get a flush of red ink into your syringe. And of course, the same happens when you inject into a human being. I was talking to I've forgotten her name, but I was talking to a dentist yesterday, sorry, and she said, whenever you stick your needle in, you always withdraw to make sure you're not in a vessel. And that's what I taught student nurses for 30 years. Then the World Health Organization, about 10 to 15 years ago, decided you don't need to bother. So when you stick the needle in, there's a proportion of intravascular injections. And yet these World Health Organization guidelines have found their way into what we call the Green Book in my country, which is the definitive thing for giving vaccines, that you do not aspirate anymore. And yet we know that there's blood vessels in the area because we compare it back to basic science. Why on earth would we be giving injections wrong? It really is quite hard to explain. So we feel free to ask these basic questions. So let's turn round, have a look around, see what's going on. Reality orientation is always good. This is a friend of mine who likes photography, but we like these posters. All these posters and the books are available for free download. If you'd like to print one out and put one on the kitchen wall, you're more than welcome to do so. So let's try and light up some darkness. Have you seen this picture before? Yeah, great picture. Hard to see on that, but everyone's conforming. You will conform. You will conform under threat of punishment. You will conform. But hey, one man didn't. August Landmesser, Hamburg shipyards, 13th of June, 1936. He refused to conform. He died, of course. He was executed. He died in a penal regiment for his resistance, but he didn't conform. So one man from that crowd walked away that day with his head held high. He didn't conform. And we're pretty sure this is genuine. Ernest Shackleton. Do you fancy a hazardous journey? We're not going to pay you very much. Bitter cold, long months of complete darkness. I'm up for this, are you? Sounds great. Safe return doubtful. Honour and recognition in case of success. Ernest Shackleton. And 3,000 men applied for that. Are we going to apply? And then this guy, John the Baptist, replied in the words of Isaiah the prophet, I am the voice of the one crying in the wilderness. But then the Lord came. So we often feel alone, but, I think we're right. I think we're right. Lots more examples. I'm going to get a stop sign in a minute, so that's okay. But another thing we do is we try and pick low-hanging fruit. So this monkey's smart. It's picking the low-hanging fruit. There's so many things that are easy to get. And the first one is equality with patients. This is sorely missed all around the world. So this could be an individual doctor, or it could be a government, or it could be a regulatory agency. If you're in the pit of ignorance, thank you, regulatory agencies. You're very kind to us mere mortals. Throw us a few crumbs, chuck us a pill, give us a jab occasionally. No, that's not the way we should do it. Healthcare should be of the people, for the people, by the people. We should be brought up to the land of knowledge. Now, our regulatory agencies might not do that for us, but we can do it for each other. We can do it for our individual patients. They're just fallible human beings, the same as we are. That's from a book called Where There Is No Doctor by David Werner. Low-hanging fruit, patients often like it. It's often dirt cheap. We worked out that ivermectin tablets, the World Health Organization, about 10 years ago, but it was paying about 2 cents a tablet. It's basically free. Can be manufactured in huge amounts. Available to all, very often not under patent, strangely enough. So the pharmaceutical industries aren't making huge amounts of patent money. Very often natural or repurposed. Good risk-benefit analysis. You know, basically, if I'm ill or my friends are ill, I'm prepared to try anything as long as it's not doing any harm. That's a big factor. Low skill of administration. Often this can be done easily in the community. Very often there's consistency between a scientific way that it sounds like it's working and what we're actually seeing in practice. And often there's limited randomized controlled trial data because you don't make much money out. You don't make much money out of it. Another aspect of low-hanging fruit, vitamin D deficiency. I was amazed how common this is in Australia, in sunny Australia. But I was disappointed that Dr. Grimes here, he did some of the original research on this in about 1990. He told me at my age you make very little vitamin D even in the sun. So we need to titrate our levels of vitamin D. And again, evidence-based communication, able to talk to world-leading experts. This is the guy who did the original research back in the 90s, straight from the horse's mouth, make the world vitamin D replete. Easy to do, cost nothing, could revolutionize a whole range of conditions, including cancers. Again, I've talked to Professor Gus Dalgleish about this. It's a big factor in the etiology of many cancers. And we can give it vitamin D is activated in the body, but if someone's acutely ill and they're low on vitamin D, we could give calcifediol. Again, is this effective? Dr. Grimes, and this is Professor Anderson, who did a lot of the original work who I've talked to as well. They believe so. Let's do a trial on that. It doesn't need to be an organized trial. We just need to collect the data as we go along. So when someone's acutely infected with something, viral or bacterial, maybe we can optimize the efficiency of their immune cells by giving this calcifediol, because this works in about 2 hours. And that's quicker than antibiotics. They take, 8, 12 hours to start working. Again, simple things that we are not doing, not even considering. Ivermectin is an obvious example, isn't it? Obvious example. Santoshi Amuro, William Campbell, Nobel Prize, jointly awarded, 2015. And the way that the clinical trials on ivermectin have been done, it just shows all the deficiencies in the pharmaceutical system. The trials have been designed to fail. And the ones that were successful, the results simply aren't published. Go on to ivermectin.meta, see the data. It's completely convincing of the efficacy in COVID, and probably, we don't know, but probably other viral infections as well, and probably even other conditions. Why aren't we doing that? Our own Professor Robert Clancy has developed oral immunobiotics from a particular bacteria. This is just is it a capsule, Robert, or a pill? Just something you swallow that boosts the immune system. Cheap, readily available, not sponsored by Big Pharma. And Professor Angus Dalgleish, he's developed something similar that upgrades the immune system. But again, the Medicines and Healthcare Products Regulatory Agency in my country will not, unfortunately, authorise it to allow doctors to prescribe it off-label. I suspect I'm already over time. Another minute, or we're done? Well, one more minute. Okay. Can't remember what's next, actually. Yeah. Oh, yeah. The whole idea of plant-based medicines, natural-based medicines, and fungal-based medicines. This one is a particular type of mushroom I've grown myself. I grew that one myself. It's called lion's mane, and it seems to have properties which help the nervous system regenerate. Quite incredible. My brother had quite severe post-concussive disorder and was dramatically better after taking lion's mane. Where are the large-scale international clinical trials on this? You know, if you're a doctor or a nurse here, you know, the idea that we have something that could cause central nervous system neuronal regeneration is just amazing. You know, we've been told all our lives that the nervous system cells don't regenerate, but this seems to help. Or maybe it doesn't, but let's do the trial. But of course, there's no money in it. You can't patent mushrooms. Thank you very much.
Really appreciate that.